My name's Sean Picorni. I'm one of the third-year cardiology fellows at Duke, and today with us we have Dr. Neil Stone, professor of medicine at Northwestern, as well as the chairman of the new ACC-AHA guidelines on cholesterol. Thanks a lot for joining us.
Pleasure to be here, Sean.
So I thought I'd start by just asking you to talk about some of the changes in the guidelines that we've seen.
Right. Well, the biggest change is we've tried to more closely align the recommendations that we made to the evidence. It was really a very arduous process. It took a long time. Number two, we found out that LDL goals, which we've used for a long time in cardiology, we really couldn't find the supporting evidence to find a specific number that was better than another number. 100, better than 90, better than 80. Indeed, we found out that the evidence from all the trials that accumulated pointed to focusing on the intensity of therapy. And it turns out statin therapy turned out to be the drug choice that best reduced the risk of heart attack and stroke. Three, we focused on heart attack and stroke both. And so we didn't want to just be limited to preventing coronary heart disease. That's important because almost a third of Americans die of heart attack and stroke, and more than 60% are going to get a heart attack and stroke. It's a big problem. And so we came up with 4 simple groups that the doctor needs to remember. Those with secondary prevention. They've already got atherosclerotic cardiovascular disease, the heart attack and stroke we've talked about. Those with diabetes, 40 to 75, because that's where the best evidence is for benefit from the statin therapy, along with adherence to a heart-healthy lifestyle. Third, those with familial hypercholesterolemia, essentially. In other words, those with an LDL-C greater than 190. To be sure, some won't have FH or familial hypercholesterolemia, but a lot will, and they've got a high risk from birth, and they need intensive therapy. And lastly, primary prevention. This has been an area of great controversy in cardiology, as some have contended that we shouldn't give drug therapy to primary prevention. And yet we would argue that takes an awful lot of heart disease and stroke prevention off the table. Can't we find from all the studies that have been done what are the characteristics of people who benefit most? We looked at 3 of the best randomized clinical trials on primary prevention, and we looked at meta-analyses or systematic reviews, collections of information that were critically analyzed, with quality being an assessment for getting in these analyses. And what we showed was that we could come up with some cutoffs with a risk calculator that was designed. Our risk calculator, unlike Framingham, looked at a heart disease and stroke risk. Framingham looked only at coronary heart disease. Our risk calculator included data on African Americans because we had some biracial cohorts that gave us important data, so now African Americans could have their information on the table. We wanted purposely, though, to acknowledge the fact that no calculator, no numbers estimation is perfect. Our calculator has a good rank order. From high to low, it's very good. And we feel at the end of the day, it discriminates well because most of the problems that some people have pointed out are in the very high-risk group where, frankly, they're going to be treated anyway. In the middle risk group, we accepted the fact that our calculator, even before we heard criticism, might overpredict. So we purposely chose a 7.5% cutoff, that's heart attack and stroke, ASCVD risk, instead of 5. So even if we're off a little bit, you're still in a benefit group. And in addition, just to make sure that we did the right thing, because that's what we care about. You know, I've practiced cardiology at Northwestern for 43 years. You were such a great student and resident there. And what we decided to do was to insist on a risk discussion before any prescription be given. So if a patient looked like they had an obvious contraindication for a statin, that's not going to be written. If a patient's preference was not to take a statin, that would be discussed, and if appropriate, a statin's not going to be given. We're bringing the patient into the equation for the first time so they can ask these hard questions about, is this right for me? And it also allows us to bring in 6 factors to the discussion if the risk assessment is not fully satisfying, and that would be 1, is the LDL 160 or more. That could sway you toward treatment, because clearly people who live at a high LDL benefit over time? 2, do they have an elevated HSCRP of 2 or more? 3, do they have a strong family history of premature heart disease? My family, people die very early. And when I was 35, there weren't statins around, but it would have been an obvious choice because very few of my relatives get past 48. This allows you to take that into account. 4, a coronary artery calcium score. If used appropriately, this can help you with decisions that you need to make about risk stratification. 5, ankle brachial index, a test that measures blood flow to the legs when abnormal. Really good sensitivity and specificity for atherosclerotic vascular disease. And lastly, an assessment of lifetime risk. Because at the end of the day, there may be some people who are not yet 40 or not yet 50 who really have such a high lifetime risk because of their risk factor burden, who we would be foolish not to consider for statin therapy, and that's the main word, consider. In other words, we've put the patient back into the decision in primary prevention. We've put the physician back in, the patient back in. Now, did we think we got it right? We were encouraged that after we had made our decisions, some additional data came out this year to suggest that there's even a mortality benefit in primary prevention. The well-respected Cochrane analysis, which said there wasn't in 2011, now with additional data says there was in 2013. So clearly, we think when a patient comes in and can go over the risk calculator with their doctor, you can talk about age, why some people just age alone will get them a high enough score, and they've got to decide, is that enough to make me want treatment? What about race? If you're African American, you've got to think about stroke risk. We couldn't do this before. Are we going to walk away from not talking to people about that? Number 3, sex. Women have a higher stroke risk than men, and the calculator allows us not to walk away from them. 4, we look at blood pressure and whether it's treated or not. 5, the cholesterol and the HDL. We've got to, of course, ask if they have diabetes. So this whole risk discussion, we think, ought to be part of the answer to the patient who says to his doctor, "Doc, what's it going to take to get me to lower my risk of heart attack and stroke?" And we think these evidence-based guidelines allow you to start. Remember, the risk calculator, which is under discussion today, is where we start with the risk discussion. It's not where we end.
Great. I think it's all very interesting and insightful. The other question that I had was in terms of performance measures for patients and physicians, now that the LDL targets are no longer there, what do you recommend for performance metrics?
Well, I think the performance metrics really ought to be, has the person's risk group been appropriately assessed? Were they asked if they're a secondary prevention candidate? Were they assessed to have diabetes in a range where we know statin treatment makes a significant difference? Do they have an LDL 190 or more despite diet and, of course, no secondary factors? And if those are present, the appropriate condition is a prescription of not just diet, but the appropriate intensity of statin therapy. And for primary prevention, it's not just getting their LDL below a number. That would result in, frankly, a lot of overtreatment. But it's assessing their risk and finding out what factors make sense. I think we've got to get away from one number tells all. I like to say to people, it takes much less intelligence to shoot at a number than sit down with a patient and decide what is the best therapy for them. That's what doctors do. That's what we should be doing.
Well, that's great. Well, thank you very much for joining us today. We really appreciate your time.
My pleasure.